Welcome to the ACMG Knowledge Nugget on newborn screening for beta thalassemia. This activity is intended for educational purposes only. Neither I nor the planning committee have any disclosures. This session is approved for 0.25 CME. To obtain CMEs for this activity, you will need to pass the quiz with a score of at least 80% and complete the evaluation. This session is a companion to the Beta Thalassemia ACT Sheet, which is freely available at www.acmg.net/ACT. ACT sheets are intended to be immediate resources for providers who encounter positive newborn screening results. Please keep in mind that a newborn screening result is just the first step in the diagnostic process. Further testing and evaluations are needed to determine if the newborn has the disease, a true positive result, or is unaffected, a false positive result. The ACT sheets are intended to provide an overview of the diseases identified by newborn screening and clear next steps for the management of a positive newborn screening result. This session will cover background information on beta thalassemia, including clinical features and the underlying genetic cause, actions a primary care provider needs to take upon receiving a screen-positive test result for beta thalassemia, clinical considerations, and supplemental resources. Beta thalassemia is a genetic condition caused by pathogenic variants found in the HBB gene. These genes are responsible for making the beta globin protein found on the beta chains in hemoglobin. Normal hemoglobin is composed of 2 alpha chains that contain alpha globin and 2 beta chains that contain beta globin. In beta thalassemia, there is a decrease in the amount of beta globin produced, which results in fewer beta chains and ultimately less functional adult hemoglobin, which is also known as hemoglobin A. Those with beta thalassemia have a low hemoglobin level or anemia and an elevated number of immature red blood cells, as well as abnormally shaped and pale red blood cells. Severity of this condition depends on how many beta globin genes are affected. The more beta globin genes that are affected, the less working hemoglobin is present and the more severe the signs and symptoms. There are 3 main types of beta thalassemia: severe, also called transfusion-dependent beta thalassemia or beta thalassemia major; moderately severe, also called non-transfusion dependent beta thalassemia or beta thalassemia intermedia; and mild, called beta thalassemia minor or beta thalassemia trait. Babies born with this condition are typically asymptomatic at birth, but can develop mild to severe anemia within the first 6 months of life, as the fetal hemoglobin switches to production of the adult hemoglobin. Infants with the mild form of beta thalassemia may have very mild anemia and typically do not show symptoms of the condition. Infants with the moderately severe or severe form of beta thalassemia show signs and symptoms of microcytic anemia, including pallor, excessive fatigue, shortness of breath, irritability, excess iron buildup or hemochromatosis, a large spleen and liver or hepatosplenomegaly, and yellowing of the skin and eyes or jaundice. Without appropriate treatment, complications can include infection, failure to thrive, and bony deformities, particularly of the face and head. Beta thalassemia is inherited in an autosomal recessive manner, meaning that only infants with a pathogenic variant in both of their HBB genes will be affected with the severe or moderately severe form of the condition. If only one biological parent passes down a non-working HBB gene, the infant will have the mild form of beta thalassemia or beta thalassemia trait. Parents with a child with beta thalassemia are carriers and are usually unaffected, but have a 25% recurrence risk with any future children they have together. Currently, not all states or territories in the United States provide newborn screening for beta thalassemia. However, all states screen for sickle cell disease, which can detect decreased levels of normal hemoglobin or hemoglobin A and other hemoglobin variants associated with beta thalassemia. A good resource for checking a state's newborn screening panel is the newbornscreening.hrsa.gov website. Screening for beta thalassemia is performed by examining levels of certain hemoglobins that are present in those with beta thalassemia. Newborn screening programs use either isoelectric focusing or high-performance liquid chromatography. These assays will show only presence of hemoglobin F or fetal hemoglobin, or presence of hemoglobin F and a decreased presence of hemoglobin A. Molecular genetic testing is required to confirm the type of beta thalassemia that is present. Now that you have an understanding of what beta thalassemia is, let's talk about what to do if you have a patient screen positive for beta thalassemia during newborn screening. You will need to take the following actions. First, contact the family and do the following. Inform the family of the screening result and that more testing is needed to determine if their child does or does not have beta thalassemia. Ascertain clinical status. Newborns are expected to be asymptomatic. Provide the family with basic information about beta thalassemia, including the need to monitor at home for pallor, yellowing of the skin and eyes, irritability, or decreased energy or feeding. Second, take a family history. Parents of those affected may or may not also have signs and symptoms of beta thalassemia. Third, arrange an immediate referral to a beta thalassemia specialist for a comprehensive clinical evaluation, discussion of a treatment plan, and genetic counseling. The specialist is typically a pediatric hematologist. The clinical evaluations should include a comprehensive physical assessment by an experienced beta thalassemia expert. Fourth, working with the appropriate specialist, take steps to ensure confirmation of the newborn screening result. Confirmation by molecular genetic testing is necessary to provide a definitive diagnosis. Fifth, report the final diagnostic outcome back to your state newborn screening program. Management of beta thalassemia is dependent on the type of beta thalassemia that is diagnosed. Those with beta thalassemia trait can be followed by a primary care provider after referral to a genetic counselor. These individuals typically do not require medical treatment. For those with the severe or moderately severe form of beta thalassemia, frequent blood transfusions and medications to reduce extra iron in the body, called chelation, is necessary to limit complications. Additional treatment includes modified immunization schedules, treatment of acute illnesses, and monitoring for early signs of organ damage. As you continue to care for your patient with a positive newborn screening result for beta thalassemia, it is likely additional questions and concerns will come up. Here are some resources where you can obtain information on beta thalassemia, appropriate laboratories and tests, and genetic specialists. Before we end today's session, Let's have a quick review. First, beta thalassemia is a serious condition. An identification of affected individuals is essential for the administration of early treatment. Second, newborn screening can identify beta thalassemia, but molecular genetic testing is needed to determine the severity of the condition and to guide management. Third, ACT sheets are freely available on the ACMG website to review in the event of a screen positive result. In addition to beta thalassemia, ACT sheets are available for many other conditions that can be identified through newborn screening.